feedback, I apologize. So, good morning. Thank you for showing up on what's going to be a very nice day for the usual PCEP talk. Before I get going, I want to introduce Dr. Preston Fedor. Dr. Fedor is joining me as an assistant MPD. Dr. Fedor is a boarded ER physician. He's going to be working at P-South Southwest in the ED. He's also had a couple of fellowships in EMS medicine. Most recently has been from in Albuquerque, working as an EMS physician and ED physician, and spent a year as a helicopter physician working with paramedics in Australia. And so when you get a chance, say hello to him, and we'll welcome him. And I'm planning on using him extensively. I need more vacations.
Yeah, you do.
Yeah. So today we're going to talk toxicology and other things. We just put toxicology because Mark likes the picture. And so we immediately talk about spinal immobilization, what is near and dear to our hearts, because, well, we'll go through this case and we'll talk about it. So this patient was filling up on fuel, and somebody heard a loud noise, and the group around the patient began laughing, and the EMS looked over, and the patient had hit his head on the vehicle that they're refueling. Apparently he came up underneath it in some odd way. He was not knocked out. He walked over, asked for a bandage due to some bleeding, then felt dizzy and suffered a syncopal episode. Went to the ground, unconscious for maybe 20 seconds, woke up, alert and oriented times 4. Is this a traumatic concussion? Sounds to me like it's a great big guy who has a syncopal episode at the sight of a little blood, or maybe a little pain, so it's a vagal response. But he had a half-inch laceration at the top of his head, hit his head underneath the paving truck, which his coworkers, of course, are laughing at him, denies head pain or back pain or neck pain. GCS, prior to arrival of the ambulance, quote, spinal precautions, C-spine is cleared. Kind of iffy. Are we clearing a C-spine on that kind of case? Okay. Wound care, direct pressure. He's alert, oriented, person, place, time, remembers the event, has no issues about that. Got an IV, GCS is 15, blood pressure is stable, pulse is stable. ECG shows normal time. Boy, I mean, we had the full meal deal. Modified trauma activation. Okay, this buys you a C-collar and a couple of other things. So, spinal immobilization, appropriate patients for long backboard immobilization are blunt trauma with altered level of consciousness. That means altered level of consciousness. Spinal pain and tenderness, neurologic complaints, anatomic spinal deformity, high energy mechanism with any of the following: intoxication, inability to communicate, or distracting injury. Don't think any of those are there. So, these are the things we consider: mechanism injury, and then patient mentation, whether there's impairment due to drugs, alcohol, or pain, subjective assessment, cervical, thoracic, lumbar, spine pain, numbness, tingling, burning, objective assessment, any deformity or tenderness, distracting injury, pain with cervical range of motion. If yes to anything, we immobilize. If no, you can treat and transport without immobilization. So if there's penetrating neck injury without neurologic deficit, we don't do spinal immobilization. We don't do C-collar because you can't see. You can't see. You can't take care of it. If there's no neurologic deformity or neurologic deficit, there's not an issue there. So we will consider immobilization with C-collar, immobilization of the gurney if the patient's ambulatory at the scene, requiring long transport, or where a long backboard is otherwise not indicated. Now, as far as I'm concerned, the best thing about a long backboard is you're able to get the patient off the ground and onto the gurney. I mean, I've had that experience. It was very difficult for me to move comfortably with fractured ribs without being picked up fairly firmly. So a long backboard worked out really good. There's nothing wrong with my neck, although they didn't know that at the time. Now, minimizing movement, attention to spinal precaution is still the rule. All patients, now this is the rule for the trauma surgeons. So you can say this case came to our attention because of one thing. All patients who meet trauma system activation, whether it's modified or full trauma activation, will have, due to blunt trauma, not penetrating, but due to blunt trauma, will have, at the minimum, cervical collar or immobilization by another method if they can't, if for some reason you can't fit or tolerate a cervical collar, and then be immobilized to the gurney in a supine position. So this person came in semi-foul, sitting up. So immediately they yell at us, and then I get to yell at you. Now, when you, and there are a lot of people, old people, people with kyphosis, people with respiratory issues that can't lay supine because they start getting short of breath. Or they can't lay supine because they say, oh, I'm getting nauseated. Put them in reverse Trendelenburg. Your gurneys all change position now. They're still supine, but they're reverse Trendelenburg, and everybody's happy with that. There's no change in their spinal position. So put them in reverse Trendelenburg. Trendelenburg is head down, right? Reverse Trendelenburg is head up. Whole gurney moves that way.
Our gurneys don't move that way. We'd have to be on a backboard. And, I mean, we can sit them up, but our gurney doesn't move flat at an angle. It only sits up, unless I'm wrong.
Remarkably, you're right, Trevor.
Remarkably?
I'm a little surprised too, honestly.
Well, if you can't put them in reverse, if you can't do that in a, without a backboard.
Yeah, you don't do that with board.
Only do it with the backboard, huh? Well, I don't want them all on backboards. So we'll just have to go back to, the trauma surgeon and say, hey, some people are just, you know, but supine is their preference. Now, so if you can document, if you don't have them supine, document why. And document, and incidentally, nobody who we've brought in semi-Fowler, sitting up, nobody has had a problem. Nobody's had a cervical injury.
Dr. Weber, the one issue though with this particular case, and if you could just reiterate the fact that the protocol exists for a reason, that this guy met C-spine criteria. He had a loss of consciousness
Yeah.
in front of EMS.
Although the loss of consciousness was most likely simple vasovagal or vagovagal syncope.
Okay.
But you can't prove that
Right.
in the field. I mean, we're not definitive yet in the field on all. You don't have to diagnose the appendicitis. You just have to say they have abdominal pain. That's That's your rule. So, okay, so supine. There's another case that we should have put in here too. A lady who an older lady who had a fall was complaining of stuff and couldn't remember the fall. Refused transport. Her husband was bad. She adamantly refused transport, and her husband, capitulated to her. Because she couldn't remember, I had some significant concerns that this patient was not, competent to refuse. And no one called medical control about it. Well, she calls 911 a day and a half later because of her severe neck pain. And she gets a cervical collar, gets transported, but when they lay her down, she says, "Oh, I don't feel good. I feel nauseated." So they sit her up and give her some Zofran and transport her. Well, she has a C1, C2 unstable fracture that she ends up getting a neck fusion. She didn't refuse that, interestingly enough. But, we're trapped with, sometimes you're trapped, but the two things on that one, patient should not have been laid down. She should have been better probably should have treated her discomfort and her, and they took the C-collar off, by the way, too, because she didn't like the C-collar. Goes to show old people are annoying. Being an old person, I could be annoying, too. So that case, that would have been a simple medical control thing. And then, of course, they were upset because she came in sitting up also. You can't win. Okay, toxicology. Priority 2 for a psychiatric suicide attempt, possible carbon monoxide inhalation for a 74-year-old male patient. Dispatch states the patient's daughter was on scene and found a note, believed the patient tried to commit suicide via carbon monoxide. Also states the patient has a history of violence and a weapon. All units are stayed. CCSO did not want rescue to go in until they cleared the scene. They did clear the scene approximately 45 minutes later. Patient's unconscious, can't provide any information, and they didn't allow the family members to come into the scene, so we couldn't get any information from the family either. AMR, CCSO was on scene. This is fire. Patient located a significant distance behind the house in the woods. Area is accessible only by small response vehicles. Patient is on the ground next to his vehicle, responsive to painful stimuli, strong radial pulses, had a patent airway, hose running from the car's exhaust into the passenger compartment. Original caller found the patient inside the vehicle with the car running. There were pill bottles in the car believed to be morphine as well as anxiety meds, some kind of med ending in PAM. I don't think it's a vegetable spray, so I think it's an azepam of some sort. GCS is 9, pulse ox 86 and room air, started with 10 liters non-rebreather, temperature 96.6, pulse ox then 100, lung sounds were clear, CO2 value 21. Trying to start IVs, naloxone given IV 1 milligram, improved, it says. GCS now 10, naloxone again a milligram, blood pressure is good, pulse is good, GCS is still 10. Now, nasal cannula, 4 liters now given because, quote, patient's EtCO2 dipped to 19. I didn't know that was going to affect your EtCO2. I mean, what's the treatment of carbon monoxide poisoning? High flow oxygen. You should have just stopped him breathing, right? His CO2 would go up. That's not true. Don't take that home. Okay, GCS is still 10. At the hospital, his GCS, his CO2 level was only 4.2. I mean, it's not even as good as a 2-pack-a-day smoker. Had multi-drugs, Ativan, morphine, alcohol, spent 6 days in the hospital, no apparent ill effects, was reprimanded. He ultimately went with law enforcement because he had a previous issue related to his difficulty with his having a gun and a few violent kind of things. So this goes to show a couple things. It's almost impossible to commit suicide in a Prius by carbon monoxide. And most things are multi-drug. But how do we take care of, what is carbon monoxide? How do we take care of it? So carbon monoxide is incomplete combustion of carbon-containing material. It should make, if you have complete combustion, you get CO2. Okay? Unintentional exposure to carbon monoxide is more common in northern climates. There's about 500 plus deaths per year that are not fire-related. So obviously there are fire-related deaths, but they don't. The unintentional ones that are not related to fire, about 500 per year. Sources of carbon monoxide: engine combustion, gas and coal heater emissions, tropical rainforest burning, cigarette smoking. A heavy smoker can have up to a CO level of 8 to 10, which would be very symptomatic. You'd be very symptomatic if you weren't chronically exposed to it. Paint stripper. The reason they tell you on the package to have good ventilation is that as you're using paint stripper, it's a methyl chloride, and it puts out a CO, and you end up getting carbon monoxide exposure if you don't have good ventilation. And when you burn your little, camp heaters, you're supposed to have good ventilation for those too. So there's a lot of potential carbon monoxide sources in the average house. Anything that has, we've had carbon monoxide deaths from semi-homeless people living in garages and running gas and charcoal grills for heat without adequate ventilation. It's an odorless, clear gas, colorless. Now, it's a naturally occurring thing in our own system. We produce a small amount of hemoglobin, of carbon monoxide when we are metabolizing hemoglobin to bilirubin in the liver, which is probably why hemoglobin has an affinity for carbon monoxide, so that you can scavenge that very quickly, get it to the lung, and exhale it. Get rid of it. But carbon monoxide and oxygen have different binding affinity for respiratory enzymes. Hemoglobin has 250 times greater affinity for carbon monoxide than it does for oxygen. Not good if we were, but teleologically, over the history of the world, we've been, human beings have been very seldom exposed to carbon monoxide until we got pretty good at controlling, doing fires. So for the original time, we didn't have any issues with that, unless you were in the, sitting next to a volcano with dinosaurs running around you. That's a joke. Myoglobin, the oxygen affinity globulin of the muscle, has a 20 to 25 times greater affinity for carbon dioxide. So carbon monoxide just wants to be sucked up by hemoglobin and myoglobin, which is why when you're exposed to it, it's a bad deal. So CO2 or CO binds to hemoglobin, reduces oxygen transport, and reduces its availability to the tissues. And the tissues aren't as, they're much more attractive to the carbon monoxide than they are to oxygen. So essentially it causes what we call a left shift in the oxyhemoglobin dissociation curve, which is a complicated curve as you look at that. But what it means when you go leftward, it means you have to have a higher concentration of oxyhemoglobin saturation in order to give up oxygen to the tissues. Means that your tissues starve for oxygen. Hemoglobin is all taken up by the carbon monoxide. Clinical features start out with fatigue, malaise, vague flu-like symptoms, nausea, vomiting, difficulty thinking, concentrating, emotional lability, so they're very often very tearful, very sad appearing, dizzy, weak, lethargic, paresthesias, numbness, tingling, odd sensations. As we progress down, they go to stroke or coma or seizure because of lack of oxygen. So they have basically an ischemic-induced episodes of coma, seizure, or stroke, and ultimately respiratory arrest. Now, they also, at the same time, get cardiovascular symptoms because of essentially ischemia. They're not carrying and delivering oxygen to tissue. So ischemic chest pain, angina, palpitations, dysrhythmias, poor capillary refill, mottled skin, hypotension, cardiac arrest. Symptoms get worse, particularly if someone is in a closed situation with incomplete combustion, a house fire, some sort of an incident where you've got motors running and they aren't exhausting well. And if you increase exertion, which increases your oxygen consumption and oxygen need, symptoms get worse very quickly. So escape to safety often will put them into the extreme end of the exposure. Comorbid factors, which anything that increases oxygen demand, trauma, other drug ingestion, in this last case, burns, existing myocardial ischemia, cerebral vascular disease, existing, and then just plain smoke inhalation affecting your respiratory function. On the right-hand side of the thing, generally people who have less than 10% carbon monoxide don't have any major symptoms. They may complain of a little bit of slight headache, but between 10 to 20, most people have a severe headache. Like I say, heavy smoker may have a chronic 10% hemoglobin or carboxyhemoglobin, and they don't complain of headaches because they're used to it. At 20 to 30, increase in respirations, drowsiness, headache. 31 to 40, they have a severe headache, impaired judgment, shortness of breath, increasing drowsiness, blurred vision. 41 to 50, pounding headache, confusion, shortness of breath. Over 51, over 50% unconscious. Ultimate death if they aren't removed for that sort of source of CO. Now, a couple of things make it worse. It turns out that fetal hemoglobin is has an increased affinity for carbon monoxide. So pregnant women, even if they have a lower level of carbon monoxide, are at, the fetus is at extreme risk because the fetus is essentially scavenging the carbon monoxide from the mom. So, airway management, 100% O2. Intubation if they're apneic or if they're deteriorating. So use your rule, if we generally intubate people if they've got a GCS of 8 or less. Now, so if we suspect carbon monoxide poisoning, so altered mental status with multiple patients, now, because they have flu symptoms, you're kind of suspicious that they flu symptoms in the wintertime are pretty chronic. You see them, you go out on a lot of different flu kind of thing. But if everybody in the house is sick, and the dog is sick, and the canary is dead, you might consider carbon monoxide. 100% O2, and CPAP makes it work better. Studies show that if you put CPAP on with 100% O2, even at low levels of CPAP, you will clear 3 times faster. Now, we've used that in the past for, occasionally we've had firefighter exposed at a fire scene because there's something wrong with their apparatus, or they've taken it off because they think it's okay to clean up at that point, and they get CO2 or CO poisoned. We clear that with, that improves greatly with CPAP. Now, obviously, the patient has to be able to tolerate the CPAP. So an unconscious person, you can't. Now, I suppose it would be theoretically good if you put if you had an unconscious person who you ended up intubating, you've got 100% O2 and put it up, and it makes theoretically good sense to use a PEEP valve at that point, just increase O2. Now, we have commercial devices. How many rigs or how many fire rigs have a CO device? I think all of them now, right? Yeah. So determine your CO level with a commercial device. Now, those are reasonably accurate. SPCO between 3% and 25%, and neurologic symptoms, that those patients need to be treated, transported to an ED. If it's greater than 25, contact medical control, because you treat the symptoms per the protocol, but you will add a 12 lead if they have any ischemia, but you may be diverted to a hyperbaric chamber. Now, treatment with hyperbaric oxygen reduces the half-life of carboxyhemoglobin by 75% versus 100% O2 alone. Improves delivery to ischemic tissue, enhances elimination from hemoglobin, and lessens the CO induce reperfusion injury that can sometimes occur. Indication, definite indication for hyperbaric treatment is an abnormal neurologic exam, altered mental status, history of loss of consciousness or near syncope, history of seizure or coma as part of that episode, history of hypotension during or after the episode, myocardial ischemia with or without changes on your 12 lead, prolonged exposure, or pregnancy with any elevated carboxyhemoglobin. There's a couple of relative indications, and that includes neurologic symptoms after 4 hours of oxygen therapy, persistent acidosis, concurrent burns, and again, pregnancy, regardless of carboxyhemoglobin level. So, pretty straightforward. And not to be anxious about Priuses. Case 3. Arrived to find patient lying supine on a restaurant bench with fire in attendance. Conscious alert, speaking 1 to 3 word sentences, complaining of itching, full body hives, and shortness of breath with the feeling of throat closing and tongue swelling. Say she's allergic to soy, thinks she got her drinks mixed up at Starbucks. States a few minutes after drinking her coffee, she began having the reaction. States she no longer has an EpiPen because hers is expired. Patient also states she feels like she is going to pass out. Blood pressure's 79 over 38. Pulse 92, respiration's 26. IV was started 250 cc's given total. In total, by the time we're done, she's wheezing in the upper right and upper left, absent sounds in the lower lung fields. Pulse ox 90% on room air. Blood pressure rechecked 94. I'm not sure if that was after treatment or not. Med-Neb got an albuterol. Med-Neb started with ipratropium as well. And then, because this had been a bit of time, they began an epi-drip. And she indicates 0.06 milligram IV drip, because this was a 2 microgram per minute drip for approximately 30 minutes. So that's actually calculated out. So if you're giving 2 micrograms a minute for 60 minutes, you're giving 0.12 of epinephrine over that whole hour. Blood pressure's up now, 98 over 57. Got some methylprednisolone, got some diphenhydramine. Pulse ox is 97. That's so. Pulse 95. Blood pressure is 140. Here is a 12 lead. She has a little ectopy, and we don't know what her underlying is like. In hospital, patient had improved upon arrival to ED, and the epi was stopped. She was given some Pepsid, which is an H3 blocker, whereas Benadryl is an H2 blocker, a histamine blocker. Interestingly enough, she did a lot of times when they stopped the epi drip, they began having symptoms again, but she stayed stable. She was observed, however, for 3 to 4 hours, and I'll tell you why in a minute. Remained asymptomatic and was released with a new EpiPen and some Benadryl. I think they also may have given her a short dose, short burst dose of prednisone. So, anaphylaxis. What is anaphylaxis? Severe systemic hypersensitivity, multi-organ involvement caused by release of mediators and mast cell degranulation, which releases the anaphylactic active mediators. Hypersensitivity is an inappropriate immune response to an antigen. Inappropriate because you don't want a response to an antigen that's going to kill you. Risk factors are not identifiable by race, age, gender, occupation, geography. Fatal anaphylaxis increases with poorly controlled asthma, because some of the poorly controlled asthmatics turn out to be basically they're anaphylactic induced asthmatics. They're severe allergic asthmatics. Previous anaphylaxis, it makes you more likely to have fatal anaphylaxis the next time, which is why we give people who have had an anaphylactic reaction, we give them EpiPens. Anaphylaxis doesn't always recur. Now, with insect stings, it's 40 to 60%. You're likely, roughly 50% of the time, if you had a reaction to a bee sting, you're going to have a reaction, an anaphylactic reaction the next time. The problem is a bee is not a bee is not a bee. A wasp is not a bee, and a bee is not a yellow jacket, etc. And so it may be specific to the type of bee. So if you get yellow jacket envenomation and have an anaphylactic reaction, you may not have any reaction to honeybee. So that's probably why there's a less reaction. We don't take the chance into people who are allergic, if they get stung by a bee, you say use your EpiPen. 20 to 40% for radiocontrast agents, which is only a problem in the radiology suite then. 10 to 20% for penicillin. So if you tell the doc you're allergic to penicillin and you need penicillin, you may likely, you still could likely take penicillin, but no one usually wants to take the chance as long as there are other medications available. Most common causes of anaphylaxis are antibiotics, insect envenomation, and food. You have to be exposed to the antigen once before in order to have a reaction to it again. Now, you say, well, some people have had reactions, I've heard that some people have had reactions to penicillin and they've never had penicillin before. Well, that's because they've actually had exposure to the mold that started their antigenic reaction long before. So you can have what appears to be a de novo first exposure anaphylaxis, and if you had a reaction to one antibiotic, you may have a reaction to another one that's of a vaguely similar class. Causes different with age. The most common agent for pediatric anaphylaxis is food, and that's why all peanuts get a bad name, and other soy other stuff in pediatrics. So pediatrics, our most common allergic reaction is to food until they start getting exposed to antibiotics and other things. Now, clinical features of true anaphylaxis is diffuse urticaria. Now, sometimes, and in my experience, sometimes you will get there and they are just blanched white. no urticaria, but if you ask them, they were transiently itching. For some reason, transient itching seems to count too, but most of the time for real anaphylaxis, you get some evidence of urticaria, wheals, itching. Angioedema, very common. Facial angioedema, usually not as impressive as this person in the picture. Other symptoms, abdominal pain, which is one of the reasons why we get, why the Pepcid is one of our armamentariums. We treat with famotidine to knock out the abdominal histamine. So a lot of times you get abdominal pain, especially if you have an ingested thing, like one of the common anaphylactic allergies is seafood, particularly shrimp and stuff like that. And it's often associated with some abdominal pain because they ate it. Nausea, vomiting, bronchospasm, wheezing, copious rhinorrhea, conjunctivitis, itching eyes, tearing, dysrhythmias. Now, so I don't know whether her PVCs were part of the anaphylactic or stimulated by a little bit of epinephrine. It's an older person. Hypotension. So multi-system involvement. Symptoms typically occur within 60 minutes of exposure. The faster onset, the more severe the symptoms generally. It's often a biphasic phenomenon, so you get a return of symptoms after the initial attack and maybe even after you treat the initial attack, which is why we watch the patients for a prolonged period of time. That biphasic event, they get an immediate release of the histamine type things for the anaphylaxis, and then later on they get release of leukotrienes, which are another type of anaphylactic inducing chemical. Diagnosis, history of exposure. Diagnosis may be difficult if there's a prolonged delay of symptoms. Now, how do we treat it? A severe reaction, dyspnea, wheezes, laryngospasm, hypotension, shock. I love, as you know, IV epi drips. And the orders, a milligram of epi in 500 cc's of fluid gives you 2 micrograms per cc. A milligram in 250 gives you 4 micrograms per cc. For an adult, start at 1 cc's per minute, 2 micrograms, or a half cc if you made the double dose, and increase every minute as needed by symptoms. So you're titrating heart rate, blood pressure, presence or absence of PVCs. Now, PEDS dose, and actually adult dose for that matter too, is 0.1 micrograms per kilo per minute. But it's easier to, when you're under pressure, for the adult, just to think of it on the easy way. Now, this is not truly an alternative dosing, but I wrote down alternative dosing. If the patient is in profound anaphylaxis, so that they're hypotensive, you're going to have to search, it's life-threatening. You're having to search for an IV site. Give them a dose, IM, adult or child. You're going to look for your IV anyway, and when you get your IV established, go ahead and start the drip. We don't know how fast it's going to be absorbed, IM, but it will be absorbed to some, and it may be life-saving sustaining. Then you just start titrating your dose based, again, on how they react. Just be aware that once they start getting perfusion again, they're going to suck up the rest of the epinephrine you gave them. So I don't start at a 6 micrograms per minute dose. Start at the low dose again and titrate. Caution, adults greater than 50 or adults with a history of, with a cardiac history. So you're going to be careful with them. In actual fact, we have never had a problem. We've had anaphylactic reactions in 85-year-olds with a history of multi-bypasses who've done just fine without anything, and they got cured with a low-dose epi-drip, because it's a very elegant treatment, if you will, because you're giving such a low dose. And if you have if you have any PVCs, you just turn it down. Because if you give 2 mics a minute for a whole hour, you've only given 0.12 of epi. If you give 0.3 or 0.5 IM, I have a whole series of people with PVCs and VTAC and all sorts of stuff, because that's a pretty good dose. So I much prefer the more elegant dose. Now, along with the other things, airway, high flow, if you have to do an ET tube, occasionally somebody has severe enough angioedema that you might consider, if they don't have an airway, you have to do, you may consider a crike. I don't think we've ever done one in this county for that indication yet. Now, we've done it in the ED. EKG, IV, Benadryl, 25 to 50 IV, as long as you got the IV in there. Medneb for wheezes per protocol, Solumedrol. Now, some of the allergy folk that I've been reading don't necessarily recommend steroids for anaphylaxis per se, except if, in my book, except if they have if wheezing and angioedema is one of your findings. If they're just simply hypotensive, maybe not. But I'm still of the opinion that we should give Solumedrol, which is why it's in your orders. If the epinephrine is not effective for blood pressure, you could consider adding some norepinephrine to it as well. But my experience has worked out just fine. We've not had to go to the norepinephrine. Now, for a mild reaction, itching, hives, no dyspnea, no wheezes, no hypotension, Benadryl, IV or IM. We don't carry the PO. We should probably think about that. PEDS is a milligram per kilo with a max of 25 milligrams. IV. If you say, hey, it's a major reaction, and you start a carefully titrated IV of epi, you will not get in trouble with me. Now, some people don't like epi, and they don't like epi IM because it hurts, and they can get pretty jumpy, which is the nice thing about the Benadryl. It takes out a little bit of your jumpiness. If they have a bee sting associated with this, the thing, look for the stinger and don't squeeze the little sac to pull it out. You just sort of flick it out with the edge of a knife or something to get it loose. Okay. We're right at the middle of this thing, so let's take a break. On to another topic then. Cyanide exposure. Sources of cyanide exposure in this area, primarily industrial, either hydrogen cyanide, exposure to cyanide salts, or inadvertent ingestion of cyanide salts. Where do you find cyanide salts and hydrogen cyanide? You find them in silicon wafer processing places mostly. Smoke inhalation, hydrogen cyanide is released during combustion of nitrogen-containing polymers, and polymers can be natural, wool, amazingly enough, or vinyl, and things like that. So certain rubbers, certain vinyls, and sheep products. Then there's suicide and homicide attempts with cyanide salts. So if they have occupational access to cyanide salts, you can't go to the pharmacy and say, hey, I'd like a bottle of cyanide, please. So you have to, steal it from your place of work. Naturally occurring plant glycosides, so apricot pits and bitter almond. Why would you do those? Well, people take them as naturopathic treatments for things like cancer and stuff like that. I mean, if you got cancer, you might as well poison yourself, poison it, right? And the apricot pit basically makes a product called Laetril, which has been used in Mexico and other places for a long time for treatment of cancer. It doesn't work, but then so many other things don't.
Sorry.
Okay, that's all right. And then chronic exposure, there's a little bit of cyanide put out by tobacco smoke. So I guess they do call them coffin nails for good reason. Cassava, the plant cassava. So toxicity, if you ingest it, symptoms occur within minutes. LD50 is the fatal dose 50% of the time is between 140 and 250 milligrams. My way of calculating, if your LD50 was at 140 and you took 280 milligrams, you'd have 100% fatal then, but if you were very sensitive to it. Symptoms are delayed if you need metabolic activation to release the free cyanide. So there's in acetonitrile solvent, which is in nail polish remover, that has to be metabolic. If you drink nail polish remover, you have delayed symptoms of cyanide poisoning because it has to be metabolically activated to release the cyanide. Amygdalin, which is the Laetril kind of stuff, that if you ingest apricot and peach pits, it takes a while for your stomach acid and then metabolic activity to release the cyanide. Sodium nitroprusside, which we use for blood pressure control in extreme cases, that has to be activated to cyanide metabolically too. So, you could be overdosed and you could be cyanide poisoned by sodium nitroprusside, but we try to avoid that. Symptoms of cyanide poisoning, pulmonary symptoms, dyspnea, tachycardia, and apnea. Okay? CNS, headache, drowsiness, seizures, and coma. Sounds a little bit like carbon monoxide. Cardiovascular, tachycardia, hypertension, bradycardia, hypotension, cardiovascular collapse, and asystole. No. If you our protocol for treatment of suspected poisoning with cyanide, ingestion, inhalation, signs of poisoning would include altered mental status, seizures, coma, tachypnea, apnea, shock, vomiting, and an appropriate situation that would make you think cyanide. So you would think cyanide if somebody had a bottle of cyanide salts there, or if there was an exposure in a silicon wafer plant, or if it's a fire and there's vinyls, wools, things like that that could have been, and the patient has those symptoms, altered mental status, seizures, coma, etc. Now, we have simplified the treatment of suspected cyanide antidote, the sort of the high-level cyanide antidote is truly the cyano kit, which now costs, because you have to use 2 vials of it, and now it costs somewhere between $1,200 and $1,500 a dose. The stuff outdates in about a year, so you can't carry it on the, and it's very much in disfavor with the burn center here, because once you treat the patient with the cyanokit, which is a cyanocobalamin product, so it's a vitamin B12 congener, similar to. Once you treat a patient with that, you can't get an accurate pulse ox reading for up to 4 weeks, which means that the patient has to have an arterial line in to take blood gas sampling. And the point is, most people who are who are dead in a house fire are simply dead in a house fire. Most people who you get out and they recover, or they are still unconscious, are probably CO or smoke inhalation, mostly. But we do the old-fashioned treatment to an extent. I'll just have you carry sodium thiosulfate, which is cheap. And so sodium thiosulfate in the presence of cyanide makes sodium thiothionate, which is easily excreted and is non-toxic. So we did the simple thing. It's very cheap, and the dose is 25% solution. That's the way it comes. Infuse it over 10 to 20 minutes. If you suspect cyanide poisoning. Now, if you have a patient in a house fire or a closed space fire, which is where you would think of, and they become unconscious, and they wake up while you're treating them, that's probably not a significant cyanide exposure. If they don't wake up and you're treating them, they have good O2 sats, and you have a negative CO level, and they're still unconscious or shocky, yeah, go ahead and treat them as if they had a cyanide exposure. If you have an unconscious person with a high CO level and they're still not waking up and their O2 sats are okay, and you think, gosh, could they have had a cyanide exposure too? Go ahead and treat them with a sodium thiocyanate. It's not going to hurt them, and it may not help them, but it's not going to hurt them. Calcium channel and beta blocker poisoning. Calcium channel blockers and beta blockers are very common. A single metoprolol for a 2-year-old may be fatal. Now, signs and symptoms of calcium channel beta blocker: nausea, vomiting, headache, dizziness, confusion. Okay, kind of general with poisoning. Profound hypotension and bradycardia, particularly. May have some cardiac dysrhythms also, but bradycardia would be to the effect of calcium channel blockers and the effect of beta blockers. That's what they do. They produce hypotension and bradycardia. They also may especially bradycardia, especially calcium or beta blockers, may produce bronchospasm, wheezing. It makes asthma worse, for example. May also produce pulmonary edema, partly because of the inotropic effect, the negative inotropic effect of the beta blocker. It's just not pumping forward. Now, there's an interesting thing that happened with calcium, and we're using this to treat it now, but in the ER or in the hospital. So calcium channel blockers decrease inotropy of the heart. They also block the L-type channels in the pancreas, which decreases insulin. So your blood glucose may rise because the insulin level is decreased, but it may also be profoundly low to start with. So what we do, knowing that, is that we give the patient, someone with severe, one of the treatments or proposed treatments of profound beta blocker overdose is to use insulin and add glucose as you need, just to drive the inotropy of the heart. Now, that's why we used to have in the protocol, those of you who remember this, we used to have glucagon as part of the treatment. And it's still a good treatment, but it's extremely expensive, and I'm going to leave it for the hospital to do that. So one of the best treatments of beta blocker overdose is what we have so far, we've talked about, and the application of large amounts of diesel to get to the hospital. So your orders for calcium channel blockers or beta blockers with bradycardia, atropine, still the best initial treatment, quick, down and dirty, no muss, no fuss, for any bradycardia. Atropine, PEDS dose is 0.02 milligram per kilo, up to the dose of 0.5, up to adult dose. And you can give, I wouldn't bother wasting time with more than 2 doses of atropine. And then I would start. Now, if you have a calcium blocker overdose, give them calcium gluconate. 10 mils slow for the adult and 0.5 mils per kilo for a child, up to 10. Fluid challenge. Anytime you have hypotension, fluid challenge is good, unless they're in profound failure. Pace as needed. Now, I actually would reverse this. If you have calcium or beta blocker with bradycardia, I would start an epi drip first, because epi would treat rate as well as blood pressure. If you don't have success with the blood pressure, I would keep the epi running and add norepinephrine to it. Now, if you start the norepinephrine first and you end up with bradycardia, I would add an epi drip to it. So I'll leave some clinical judgment in your part, but if you want to treat blood pressure and rate, epi would be my preference. If you want to just treat blood pressure, norepinephrine is the preference. Any questions, issues? Okay. Hyperadrenergic syndrome. Common agents: cocaine, methamphetamine, MDMA, ecstasy. Presented with tachycardia, arrhythmias, agitation, diaphoresis, large pupils, mydriasis. Mydriasis, you know, is the $25 word. Large pupils is only gets you $5 on the nail. Hypertension, hyperthermia. So hyper. Everything is hyper. this is one of our real cases of hyperadrenergic syndrome. So, arrhythmias, treatment of hyperadrenergic syndrome including induced arrhythmias. And what's wrong with this 12 lead besides the fact that it appears to be the arrhythmia or the dysrhythmia is that it looks like a supraventricular tachycardia. What else do you see on that? Yeah, it's either a big heart or it's ST segment elevation. Now, so in the case of this person who's taken a whole bunch of Coke, I would say that that's probably ST segment elevation, and and it often goes away when they're appropriately treated, and the treatment of hyperadrenergic induced dysrhythms is sedation, Versed, and I would say that probably, depending on what the guy's blood pressure is, 5 to 10 milligrams IV might be the indication here. Now, if they have stable VTAC, this is not VTAC because it's narrow complex, amiodarone would be your drug of choice for stable VTAC. Then VFib. Now, what if they were unstable VTAC? That's an interesting question because you could shock it. Probably wouldn't, maybe not help. So I would probably give some amiodarone if they're relatively unstable, like with a blood pressure of 50, 60. VFib, treat it, VFib protocol, but because they're already hyperadrenergic, I'd limit the current thought is to limit your epi to a milligram every 5 rather than every 3 to 5 minutes. Okay, a little less. Opioids, our favorite things. Common agents, heroin, morphine, fentanyl. Now we've got carfentanil, sufentanil, everything that, and as you go down the list, it becomes more potent per milligram or microgram. Signs and symptoms, primarily CNS depression, which is what they're after, respiratory depression, which they're not after, and miosis, so tiny pupils. Treatment. Now this is general treatment, not of opioid toxidrome, but general treatment for altered mental status. In our orders, 100% O2, intubation PRN, but that doesn't mean intubate them when you find them, just like, so the easy treatment first. Glucoscan, because if they're low sugar, you're going to treat them with glucose. IV. Right now, the orders are, if you think alcohol abuse is a likely thing, we do think of thiamine, but the only time you really need to give thiamine is if you're also giving glucose at the same time. So I'm probably going to throw that out this year just because it's one thing too much that we've got on the orders. Narcan. If they have respiratory depression and apnea, how do you know that? Well, apnea you should be able to figure out. Respiratory depression, if they're not ventilating, what's your CO2 tell you? Or if they're only breathing at 6 times a minute, that's respiratory depression. That's where I give 2 milligrams of Narcan, IV, IM, IN, if you can't get those things in. That's why your EMT basics and your first responders can be trained for IN if they get there before you do. if they have only altered mentation, so it's AMS, but they're breathing okay, their ETCO2 is normal, then please titrate the dose. Start at 0.5 and titrate it. Don't exceed the maximum dose as above. Now, the maximum dose, we've had a couple of cases now where we've had to use 4 to 6 milligrams of Narcan, particularly if we have some of the fancier new fentanyls out there. But ordinarily the 2 milligrams work, but don't feel bad about if they're apneic to go to 4, certainly. Now, the other caution for pediatrics is in newborns, if you're using Narcan on a newborn because you suspect the mother is an addict, the baby's an addict too. And adults, I will be interested. I'm offering a reward if you can bring me any adult other than a methadone user who has a seizure after you treat them with Narcan, because it just doesn't happen. Adults don't seize, and they withdraw. They hate your guts, and they might get mean and ugly, but they're not going to have any bad trouble with seizures. Babies will, because their brain is immature, it's not well insulated, if you will. They will seize if they withdraw. So with a baby, if you think a baby is an opiate addicted baby because of respiratory depression, titrate, figure out with your tape what the dose of Narcan for that baby is, and then titrate it up to that dose. So start out very low, because you want to treat respiratory symptoms, not withdrawal. So if the patient is opiate dependent, consider titrating the dose as well. But if they're apneic or hypoventilating, too bad. They're gonna withdraw, but you're not treating their CNS symptoms. You're treating their apnea. It's going to kill them long before their withdrawal will. Synthetics, synthetic marijuana, called incense, potpourri, plant food. Lots of different interesting brand names. I like Mr. Happy, Black Mama. Sources. Pharmaceutical research, they're developed to legitimatize THC, but not tested on humans. So distributors purchase these from overseas sources. They mix them, they use alcohol or acetate to dilute it, and then they put it on herbs, dry it, package and sell it, add a few flavors, appeal to a specific audience, like the Scooby snacks below. I'm not sure who that appeals to except for the kids who watch Saturday cartoons, but then you smoke this stuff and you get the activity. It binds to the same receptors that bind to cannabis receptors in the brain, cannabinoid receptors. An interesting thing that humans are born with cannabinoid receptors and opioid receptors, makes you kind of wonder. So it's the same receptor that THC goes to, binds stronger, however. It may also affect your NMDA receptors in the brain, which help to control synaptic interchanges in the brain and may affect serotonin levels and other things. So the effect of the synthetic marijuanas versus versus cannabis is that you get the same effect as you get from PCP or ketamine or methadone. So you get much more profound psychological and behavioral physiologic effects from it. So what you want, what they want, is calmness to relieve nausea, as THC does, but what they actually get out of it is anxiety, agitation, hallucinations, paranoid delusions, psychosis, suicidal thoughts, and then the fun physiologic things, vomiting, tachycardia, hypertension, chest pain, dyspnea, shortness of breath, tremors, etc. Treatment is totally supportive. So keep calm, restrain as needed, and then follow your chemical restraint protocol. So if they're exhibiting signs that you think are excited, like excited delirium, and how do you define excited delirium? I make it very simple for you. Excited delirium is an agitated, aggressive, hyperactive person who may or may not be on drugs, who may or may not be only psychiatric, but who you cannot approach, and you have to, without restraint. They may be violent against you, and you can't get an IV started. In that case, you're going to have to give chemical restraints by IM. And our chemical restraints for extreme agitation is Versed 10 milligrams IM, followed by Haldol 10 milligrams IM. Or if you don't have Haldol, you use Geodon at 20 milligrams IM. And you follow your restraint protocol, which does not include hog tying them and putting them on their, flat on their belly. That's not the way we do it. Now, if you think, well, our chemical restraint protocol, if the person is relatively cooperative, and you can start an IV, and you think they're agitated because of drugs, you give them Versed IV to the full, or IM to the full dose. And if they're still agitated after you've reached your full dose in 10 minutes, switch over and give them Haldol up to the full dose. Yeah.
Are these talking about, like, Haldol, I thought it was 5 and 5, but are you saying we can just give 10 if it's really crazy?
If someone is really crazy, and you think, if you write down, this is agitated, excited delirium, you can give 10 milligrams and 10 milligrams, just one after the other. Give the Versed first because it takes effect quicker. And you should get restraint. Now, interesting enough, Seattle is not using Versed or Haldol. They have some anxiety about that, and they're using, and they've gone directly to IM ketamine in pretty good doses, like at 3 milligrams per kilo dose. Yeah. And of course they'll probably get really hallucinations when they come off that, which is good. Synthetic cathinones, which is falling off in excitement, but it's around, still around in this area. Bath salts. Similar effects as methamphetamine, ecstasy, cocaine. They probably have some other things in them too. It's a naturally occurring substance in the khat plant. It's not previously regulated. I'm not sure it's still regulated by the FDA. Brand names, I love them. I particularly like Charlie Sheen. You know, I've been a fan ever since Platoon. Pharmacology, it's a 30 to 90 minute onset. Estimated half-life is about an hour and a half. Duration of effect, totally maybe 4 hours. It increases neurotransmitters in the brain, such as dopamine and serotonin. So the effects are similar to PCP and other hyperadrenergic kind of things. So it's totally stimulates. So the effects, like the PCP, they feel like they can do anything. It's, and they have excessive strength, not because they have more strength, but they have no restraint, no brain restraining them against things. So they don't feel pain as much. Agitation, severely aggressive behavior, paranoid delusions. There's the person is holding in this picture a package of Charlie Sheen. Psych behavior similar to that of PCP use, homicidal ideation and attempts, self-harm, suicidal ideation. We don't know what the long-term effects are, but probably they have depressions, etc. Likely have heart attack. One of the issues, of course, we have with people who are super aggressive, excited deliriums is that suddenly they die on you. They're not treated. They have cardiac arrests. We've had 1 or 2 in this county. So it's a pretty profound effects if you end up getting dead from it. Physiologically, increase in nosebleeds, nausea, vomiting, hypertension, tachycardia, palpitations, tremors, hyperthermia extreme, CNS toxicity, delirium, seizures, etc., and myocardial ischemia and infarction. Treatment: scene safety, supportive, symptomatic based, and you follow your hyperadrenergic protocol and your protocol for excited delirium if you think that's what it is. And I say, make it simple on yourself. If you cannot approach the patient and you want to treat them with a chemical restraint, you can't get to them without holding them down. They won't let you start an IV. That's excited delirium. Caffeine. I've just had my 4th cup of coffee today, which is right on the recommended adult norm. It's like alcoholism, the definition of a true alcoholic is someone who drinks more than his doctor, so the trick is to find the right doctor. So for caffeine, we'll do this. So caffeine overdose is a problem because we don't regulate it. And so young persons particularly can get caffeine easily, and you can get caffeine, and people who have problems with taking alcohol and other things can get into caffeine easily. So caffeinated, we don't think of caffeine as a drug, but it is. Caffeinated energy drinks really can have a lot of caffeine. So here's a little table. 5-hour energy extra strength has 242 milligrams of caffeine per serving. Now, by comparison, 8 ounces of coffee is 100 caffeine. And the recommended dose, like I say, the recommended dose for coffee per day is up to 4 cups per day. So that's 400 milligrams. So you in one of the energy drinks, you have almost enough caffeine to be 4 cups of coffee. And that's in very concentrated form. And I don't know about you. I know some of the guys that work for me at my farm sometimes are pounding down 2 or 3 of these things in the morning. So they're getting 1,000 milligrams of caffeine at one hit. They're pretty ADD at that point too. Now, interesting in this list, there's a thing called 5-hour energy decaf, and it has literally no caffeine in it. Now, why in the world would it's just sugar. So this combination of this is it's caffeine and sugar. So it's a perfect thing if you want to keep your kids quiet in the back seat while you're driving on a trip. So most commonly abused by preteens, teenagers, and young adults. So people with all-nighters, athletes, partying, mixing with alcohol and other drugs, and it can have bad problems. So what do you get with too much caffeine? Adrenergic symptoms, including insomnia, irritability, nausea, tachycardia, hypertension. When you're toxic, though, when you get too much, supraventricular tachycardias, lethargy and coma, seizures, hallucinations. It's been related to hypokalemia, altered kidney function, rhabdomyolysis. So all sorts of bad things. Treatment is totally supportive. So you're going to treat hyperadrenergic symptoms, supplemental oxygen is needed, check their glucose. ECG monitoring, treat dysrhythmias as you find them. Treat SVT per protocol. If they have the seizure, if they're seizing, anticonvulsants as needed, you go into that protocol. I think Mark likes this one because of the advertisement. Kratom, which is a tropical tree, which has the leaves have a psychoactive effect. But it says it's safer than peanuts because there are more deaths per year from peanuts than from this drug. Well, I guess that's the thing. However, the side effects of kratom are nausea, itching, sweating, dry mouth, constipation, increased urination, seizures, and hallucinations. So it could be a downside. Once again, treatment is entirely supportive. You treat what you find. There's no specific treatment. Okay, case number 4. We decided to stick the cases in. So, responded to Wintler Park for an unresponsive, unconscious male. Patient was found lying on the sidewalk outside the park, unconscious, unresponsive. ALS first responders were on the scene, and then AMR took over the airway and BVM. At this time, patient's airway was patent, but GCS was less than 8. Assisting ventilations, skin color normal. Friends tell us he's just been drinking Crown Royal all day because it's his birthday. At least a 5th. He doesn't normally drink. I don't know if it's his 21st birthday or not, but he's been unresponsive for at least 45 minutes. Bystanders were doing, quote, minimal CPR per fire when they first arrived, but the patient had a pulse, so they didn't do any more CPR. They administered 2 milligrams of Narcan, no relief, no improvement. After IV established, given another milligram, which maybe seemed to turn the patient around, be stirred, and then vomited copious amounts of vomit. Then he remained unconscious, unresponsive, so decision was made for transport and RSI. So as we go through it, pulse ox is 98, got Narcan, CO2 was 32, naloxone 1 milligram, CO2 47, CO2 41, waveform normal. I got etomidate, succinyl choline, intubated, 2 attempts. Difficulty was because he was vomiting. They had to do suction. Intubation with a 7.5. Ventilatory rate 12 with BVM. CO2 was 19. Then no waveform. EMS were troubleshooting at this time. Intubation reassessment, confirmation steps, auscultation of bilateral breath sounds, negative, epigastric sounds, visualization of the chest rising with ventilation, tube in place, yes. look at the top under intubation at 1811 says verified by ER doc in the ED. Okay. Anybody have any thoughts on this up to this point? Auscultation of bilateral breath sound, negative progressive sound, visualization of chest rising with ventilation tube in place, yes. Ooh, does that fit my protocol? What did I tell you when you have a falling CO2 and no waveform? Pull that tube, redo it. I'll give you credit for 2 intubations. Okay. Patient was alcohol and multi-drug. He was intubated for a whole day. He was extubated and re-intubated in the ED because no CO2, low CO2, there was no CO2 at that point, and low O2 sats. And he thought, okay, I can't prove it wasn't an esophageal intubation, and there may have simply been an air leak. Well, there shouldn't have been no CO2 then. So, thing is, alcohol, multi-drugs, respiratory depression, treated appropriately, Narcan, treated appropriately, check the glucose, needed to have that ET tube pulled and redone because you can't tell me that you can't prove to me that it was an intubation or it wasn't esophageal because you lost your CO2. You troubleshoot it, you make sure that your CO2, that your tubing isn't plugged. The guy was vomiting, so it could well be that, and you could check that very easily. That's easy to troubleshoot that. We go over that all the time. But if you can't prove it beyond that point, I want it pulled and redone. Here was case number 5, and this is where you heighten your anxiety about people. 42-year-old female reportedly vomiting. Arrived on scene to a casino, the new casino. Find patient sitting upright on the floor, awake, alert, and under the care of first responders. The casino has their own first responders. They are not under my direction because the casino is part of the reservation and it is a federally, it's their own nation. So they don't have to play. Patient states she had 1 large alcoholic drink tonight, after which she started to feel nausea and vomited 1 time. She states a little while after that she developed a headache. She denied falling or incurring any other type of trauma, denies drug. Initially didn't want to be transported, but was persuaded to be transported after explaining the need of transport. Patient reported her pain as a 10 of 10. She spoke in full sentences and was no apparent distress. Okay, my experience with 40-year-old females who go to casinos and have 1 drink is that doesn't cause them to have headaches that they describe as 10 of 10. It doesn't make them vomit. And usually they've had a little bit more experience in it. So what am I thinking about this case? What is your impression? What is your thought? She's speaking normally, but she's got a severe headache, of 10 to 10 headache. Yeah. Okay. So we go this. So she goes, and of course she's denying, and she didn't want to be transported originally, so I can understand that's an issue. Blood glucose is okay. Pulse ox was good. Pain scale was 10 of 10. That still makes me nervous. I don't know whether we didn't really put down a neurologic evaluation here, whether she had any neck pain or anything like that. She doesn't complain of it, but she complains of this severe headache. I don't know where the headache was. I like to know where the headache is. In the back of her head, all over her head, da-da-da. So she is taken from the casino to the closest hospital, which is Legacy. The history from the casino is actually she bent over, grabbed her head, and then appeared altered to the medics there. Now, I don't know where the translation of the information was. So they just thought she was alcohol intoxicated. This is my experience too. I mean, you grab your head and say, oh my God, I had a drink. No. Alcohol level was 0. CT showed a subarachnoid. She was ultimately transferred to Emmanuel, which is another issue that we're dealing with legacy, and she got a coil. She had a neuro interventional thing, had her aneurysm was coiled, and she did relatively well. But she had a delay in treatment because of stopped at one hospital, had to go to another hospital. This is I want you to heighten your anxiety about people who have unusual symptoms. It's okay that we treat all the, we do go through looking at the charts to make sure that the strokes have all the appropriate things done, your FAST and your LAM score and all those other wonderful things. But what we can't pick up, except by this kind of review, is when we don't diagnose a stroke or when we don't diagnose an acute coronary event. They don't show up until we find out after the fact. Well, another thing, the SUD study, sudden unexpected death study, which has been going on for, and everybody who's not AMR can close their ears at this point. This is basically a genetic study of persons with sudden cardiac arrest. It's been going on now for what, 10 or 12 years, and AMR we still need more cases, and we're still going with it. So all patients with pre-hospital cardiac arrest, even if you get ROSC, we don't do it with traumatic or violent deaths or overdoses. The procedure is to get a blood sample as quickly as possible after you get the IV going, or an IO start, get a blood sample from that, label the tube, patient's number, EMS number, put it, if you have a hospital sheet, put that, face sheet, put that with it, put everything in it. The AMR will have the baggie in it, put it in the ambulance cooler, and put it in the fridge at headquarters. That's all you have to do. You just have to remember to do it. And that's AMR only. Now, if fire is there and you say, hey, do you guys remember the SUDS? And they say no, and then you've reminded them. If they say yes, then they forgot it anyway. Oh, go right to number 1. We don't have to go through case reviews. So, any issues, any questions, any thoughts, any protocol things? All right. Well, I guess we will see you then next month.